Good afternoon, and welcome to a conversation about surviving long-term with HIV. As we said in the description, everybody is aging with HIV. If you're living with HIV, we sincerely hope that you are aging with HIV. And so we wanted to reframe our conversation. If you were on this session last year, there was a lot of conversation in the chat about long-term survivors versus people aging with HIV. And we wanted to make sure that everybody understood that we're all aging with HIV. We have a great panel of guests that will ask questions, but this is going to be a conversation. We want to hear what you have to say. Now, as in any conversation, we have some, everybody can't speak all at one time. So the first question I'm going to ask, is Moises on?
Yes.
Okay, Moises, great. My dear friend Moises Augusto of NMAC is here to help me acknowledge and answer questions and comments that may be in the chat box. So Moises, go ahead and introduce yourself. Sure. And let everybody know who you are.
Sure. My name is Moises Agosto. I'm the Director of Treatment at NMAC. We also have the program HIV 50 Plus, Strong and Healthy, and we're very happy to be working with Ronald and Malcolm with this presentation. So just put your questions in the chat and I'll be monitoring it and bring them to the panelists.
Fantastic. Thank you, Moises. We appreciate that. And so before we go further, obviously, as I said, this is going to be a conversation. And with any conversation, we know that everybody can't talk at once. So we want to have some community agreements. So the first agreement is everyone is muted to start. Please raise your hand to ask a question and do not unmute until you're recognized. Or, as Moises said, put your questions in the chat. The second thing is, please allow the panelists to answer questions from the moderator first. And those are the two agreements. Keep yourself on mute and raise your hand or put your question in the chat box and let the panelists answer first. Do I have your agreement on that? Answer yes in the chat box if you guys agree. I'm seeing yes, 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 yes. Awesome, 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 awesome. Thank you. Thank you all very much. So let's begin. According to the Well Project, long-term survivors of HIV include people living with HIV who were diagnosed before 1996, pre-HAART, H-A-A-R-T, long-term survivors, people living with HIV for 10 years and who were diagnosed in or after 1996, post-HAART long-term survivors, or people who were born with HIV. Long-term survivors cut across several age groups. Older adults who have been living with HIV for more than 10 years can be people living with HIV who are older than 50, and older adults who have been living with HIV for less than 10 years. HIV and aging, people who are aging with HIV vary by age, number of years living with HIV, experience with treatment. We have different experiences, but we're all effective by the interaction between HIV and aging. But this is AIDSWatch. And so we're here to talk about legislation, appropriation, access to care, and sexual wellness. We're here to talk and demand our civil and human rights. So today, our talking points are going to be the End the Epidemic focus on prevention does not address people living long-term with HIV. We're going to talk about the experiences of people born with HIV. We're going to talk about the experiences of long-term survivors under the age of 50 and long-term survivors over the age of 50. We want to talk about culturally and socially competent nursing home care. We want to talk about geriatrician training in HIV care. We want to talk about Medicare in HIV. Oh, and by the way, on my slide, I forgot to talk about the main thing, but we're also going to talk about sexual wellness for people aging with HIV. And that includes us over 60s, over 50s, because guess what? People over 50 and 60 are still having sex. We have a great panel today. So let me introduce my dear friend, Linda Felix. After being diagnosed in 1986, she began to educate herself about HIV and AIDS. She learned to lead, led, and to, well, I messed that up. Linda, don't beat me up, but I messed up your bio. But anyway, she began her education at Our Common Welfare, and she talks brilliantly about that. She's been featured in Ebony Magazine and on CNN. She has received numerous awards for community service. She is the founder of the Grady Hospital Long-Term Survivors Group and has served with the Metropolitan Ryan White Planning Council. She has been a member of the Georgia Clinical Translational Science Association. Linda is also the founding member of the Atlanta Women's Interagency HIV Study, WISE, Community Advisory Board, and Sister Love Incorporated. I had the honor of producing a film through Thrive SS with Linda in it called Colors on the Wall that we just released. And oh, by the way, Linda has been my friend for more than 30 years. Oh, excuse me, hold on. So Linda, welcome. Come off mute and say a few words about yourself.
Good afternoon, everyone. It is a pleasure to be here. I hope that what we discussed today will really lead to some tangible changes in what we see as response to and care for people aging with HIV. As Malcolm said, sexual health, geriatrician care, and these are all things that they never thought they'd have to deal with. They thought we'd all be dead, but we're still here and we are thriving. So I thank you and I look forward to this afternoon's conversation.
Awesome, thank you very much. Our next panelist is well known to everybody, I'm sure, on this call. Ronald Johnson, after a career spanning over 40 years, Ronald retired at the end of 2017. Ronald and I share that retirement story. We both do retirement very well. As the Vice President of Policy and Advocacy at AIDS United, Ronald's career includes serving as the New York City citywide coordinator for AIDS policy, the Associate Executive Director of Policy for GMHC, and directing the policy activities of AIDS Action, which merged with the National AIDS Fund in 2011 to become AIDS United. Johnson currently serves as the chair of the steering committee of the USPL HIV Caucus, with the HIV Caucus and treasurer of the National Black Gay Men's Advocacy. Ronald, welcome.
Thank you, Malcolm. And I'm really grateful for this opportunity to be here with the fellow panelists and all of the participants who are on the call today in this session. And I share Linda's hope that this will be a really good discussion and conversation, as much as we can have a discussion and conversation among 100 participants in a virtual environment nonetheless, because I think it's very important that we continue to raise these issues of HIV and aging. I'm very happy that we widen the conversation to make sure that we are talking about long-term survivors who are under the age of 40 and people living with HIV who were born with HIV, because we need to hear our stories, our collective stories, bring those stories to Congress and the administration, and continue to enrich what our legislative and administration agenda must be, enriching it by the stories that I hope we'll be able to talk about today. So I'm excited for what we're about to accomplish.
And we are happy to have you, Ronald. Thank you so much. Next up, Miss Antoinette Jones. Antoinette began her journey at Sister Love in April of 2018 as a peer navigator, facilitating access across care and treatment for people living with and at risk for HIV. Working at Sister Love and many other nonprofit organizations, Antoinette builds skills in racial, reproductive, and social justice. She strives to educate folks on intersections of HIV reproductive justice, the injustices of Black women encounter, as well as empower people taking charge of their sexual health. Her advocacy work focuses on challenging cultural stigmas around HIV and using creative expression to share her story and inspire others to do the same. Antoinette, welcome, and thank you for being here.
Thank you so much, Malcolm, for having me and everybody here. I'm really, really happy to be a part of AIDSWatch, and just the fact that it's virtual now is so great, because we can reach so much more people with this information, and I'm just so happy to be here. Thank you all for joining.
Fantastic, thank you. Next up is Ms. Griselle Granados. And Griselle, please make sure that I hope I pronounce your name correctly. Griselle has been living with HIV since birth, and she co-directed and produced the 2015 documentary titled We're Still Here, which depicts the stories of the first generation of people born with HIV in the 80s and 90s, who are now adults. She is the program manager of the HIV prevention services at Children's Hospital of Los Angeles. She is a member of the LA County Commission on HIV, as well as a member of Positive Women's Network's board of directors. She publicly stepped down from the Presidential Advisory Council of HIV and AIDS after the start of the Trump administration. Griselle believes that gender and racial justice approach is the only way to make an impact on the HIV epidemic. Griselle, welcome. Thank you for being here.
Hi, thank you. Thank you all for having me. So I'm 34 years old and have been living with HIV for 34 years. And so I'm really glad to be part of this conversation today to talk about all of the similarities that we have, even despite our age differences, as well as some of the unique differences that do exist in our experiences from folks who were born with or who acquired HIV during childhood.
Awesome. Thank you so much for being here. And we had one more panelist, but I'm not sure if he's on. And unfortunately, I did not get his information in time. Is Thomas on the call? Okay. All right. Well, he didn't make it. All right. So those are our panelists. Before I move further, I just realized I didn't say anything about me. My name is Malcolm Reed. I'm the Director of Programs for Thrive Support Services. I'm also the Federal Policy Chair of the USPL HIV Caucus. I'm 63 years old. I've been living with HIV since 1997, and I live in Decatur, Georgia with my husband of 23 years. Yeah, that's me. I'm just happy to be here. So let's move on. Let's have a conversation. So, the end-to-end focus on prevention does not address people living long-term with HIV. Antoinette, I'm going to go to you first. As a person born with HIV, what are your feelings and feedback on that statement?
Okay, sorry. So every time I'm asked about the end of epidemic plan, I often have to go back and reread it just in case I may have missed anything. And there are so many things that are missed in the end of epidemic plan. Like, it does sound like a great plan that they, of course, created for 2030. You know, people living with HIV have been able to see a future where HIV either no longer exists or we have a cure. So of course, this plan, when this plan did come out, it was very engaging. It was very positive or lightning for some of us, but it also did miss the mark on many things. So I think for me, as a person who's born with HIV, a young person, I'm 26 years old, a long-term survivor, oftentimes I'm often forgotten about in like just general conversations or around research or around the development of HIV. Not many people, I guess, think about the young people who during the time of the HIV epidemic were born. You know, the number of young people, and there's a lot of us all over the world, and young people, we face different society issues compared to older folks, or people who do not look like us, who do not share the same experiences as us. Like, for example, some of the things that I've experienced just aging with HIV, having to go through school age, living with HIV, having to go through sex ed while living with HIV and not feeling like I can relate to the sex ed, or oftentimes feeling embarrassed about my HIV status because of how the sex ed was taught and how my classmates may have reacted to the information that they received around HIV. So there's a lot of things that they do not focus on in the epidemic around prevention, such as like when we look at the social determinants of health around Black people or brown people or the people who are more at risk or are living with HIV, they forgot to look at the things that we face every day. They make it seem very simple in the plan, as if it's like an easy, get people into care, test people, make sure they retain in care, lower the HIV rate, and then boom, it's like HIV is cured, HIV is fixed, the issue is fixed. But they don't really acknowledge the stigmas that people face. Working at a testing center, I see stigmas every day, I gather information from my clients the same way I give them information. So I'm hearing things like, yeah, I didn't receive that in sex ed. And I can relate to that because I didn't receive some of the information in sex ed. Or that lack of education around sexual health, around HIV, and where they're getting this information from. And a lot of times, people in the community who look like us are getting information from their community. They're getting information from generations or Google now. Google is a big thing. So oftentimes, not knowing, they come into the office not knowing the way HIV is transmitted or ways to prevent the transmission of HIV, and I have to educate them. And that's a fear, that's a fear of people getting tested, wanting to know their status, wanting to even get tested. And that's a barrier too. So that's not acknowledged. And then also, when we think about the lack of education, we have to also acknowledge that legislators and decision makers have been refusing to make changes to sex ed that's, a curriculum that's comprehensive or that's inclusive to people of all identities. And the last thing I'm going to say is just, around social determinants, understanding that people who are brown, who are in brown and Black communities like myself, we don't have a lot of resources, who is a young person like myself. A lot of young people are not insured, or we live in marginalized communities. We don't have transportation, we lack safe housing. So many things that can play into it, like social support. Do we have, do we know people? Do we have access to these care services? So there's so much that can factor into their idea of prevention in the epidemic that needs to be acknowledged. And I feel like by including the community of people who are living with HIV, regardless of their age, but definitely those who are aging, who have been living with this virus for a very long time, they will be able to construct it in a way that's not just helpful towards the people at risk, but also for those who are living with HIV and aging and need to be retained in care, need to have a reduced viral load, all these things that they want to make happen by 2030.
Awesome. Well, thank you very much. Grizel, I'm going to go to you. What are your thoughts?
Yeah, thank you. So I actually echo a lot of what Antoinette said. And I think some of the things to add on to that is, right, so even just some of the things that Antoinette was talking about in terms of looking beyond biomedical markers, I think it's really important for folks who are living with HIV, and particularly for folks who are living long-term with HIV, and in a unique way for those of us who were born with or acquired at birth, just because, even if somebody can be retained in care, doesn't ensure viral load suppression, and even if they are virally suppressed, that really doesn't say anything about the quality of life. So I'm really interested in looking at that piece and having all of us start to have that conversation of what does a good quality of life look like long term, right? And so thinking through folks like me and Antoinette, who are still young. I mean, I'm not as young anymore, but thinking through, we still have a whole life ahead of us still, right? And what is that quality of life going to be? I know that there really aren't too many people who might have the same experience, who are that much older than me, that I have to look forward to, right? And so just even thinking through that from a science perspective, from a medical perspective, of what is the impact of HIV long term on somebody who is my age, right? So we know that HIV ages your body faster, but what does that mean for me and Antoinette? Like, in my 30s, should I be thinking about menopause already? Should I be thinking about bone density, right? Kind of like, what are the long-term impacts on like memory, all of that kind of stuff, even at our age, right? Because we have been living with HIV just as long as other long-term survivors. So like, I'm really curious about knowing about that piece. Right, from the medical perspective. From like the social emotional perspective, I'm also thinking about, right, like we often talk about the trauma that folks who have been living with HIV for a long time face, and the unique kind of experiences that we have witnessed, and that does include folks in our age group as well, right? Like, we also had to survive loved ones, right? Whether it was our parents, siblings, or friends who were children who died of AIDS-related complications, right? Like, we had those same experiences. We had a lot of the existential crises that folks have when you realized that maybe you were giving a death sentence that didn't come true, right? And thinking through, like, what do I do with my life now? So there was a lot of that, like thinking through, like, how do I move forward with my life and how do I plan forward? That also needs to be looked at in our age group. So thinking through like a legislative perspective about ensuring that there is access to low barrier mental health services that are inclusive of long-term survivors, inclusive of folks in our age group as well. The other thing that I think about, right, like, again, for long-term survivors who are younger, is also that there's a lot of folks who are interested in becoming pregnant and bearing children. And so making sure that we continue to support research and resources for folks who are of childbearing age. So I'm just thinking of, again, like the lifespan, right? And that when we're talking about research and service implementation for aging or the lifespan, that it also includes us that are at this like unique like intersection of right, like yes, we're like younger, but also we've been living with HIV for a long time, right? Like, we've been on all types of like medical regimens as well. Like, we share all of those things, but we don't know enough about the impact of like just living with HIV for this long on somebody who is younger, versus like, what are some of the issues that are coming up for other long-term survivors who are older that might be influenced just by the fact that it's like an older age. So I just think we need more. We just need more information about disaggregating some of that long-term survivor data. We need more research that is inclusive of and pulls out subset data of folks who were born with HIV. Yeah, so that's what I got.
All right, well, excellent. Thank you so much. So Moises, do we have any questions or comments in the chat? I see the chat box is booming, so I'm sure we have some questions.
Yeah, we have a question for Antoinette. And it said, do you feel there are enough young long-term survivors like yourself that are getting involved in the advocacy that you are, or are they more interested in just living their lives angry with having HIV since birth and not because of something they have done? The question comes from William Scott.
That is a great question. I see a little bit of both. I don't, as an advocate, and also as I try to be a leader in my community, I don't want to force people who were born with HIV. I meet a lot of them, trust me. I started doing advocacy at least 3 or 4 years ago. And in that 3 or 4 years, I've met or encountered or had phone calls or conversations with at least 150 or 200 young people born with HIV. And not all of them are open or ready to be open about living with HIV, and it's not my place to force anybody. It's just my place to empower people to recognize that, you have a voice. Your voice is needed in the community, of course, but there's other ways you can use your advocacy skills. You don't have to be a public speaker. You don't have to, write a blog or be a part of an organization. Educating your family, educating your friends is also advocacy. There are other ways that you can use your diagnosis to benefit you. And then also meet people who are fine living the life that they live, as long as they receive the education, as long as they know exactly what it is that they are living with. For a long time, I was silent about my HIV diagnosis because I was taught at a young age to keep my HIV a secret. So I grew up believing that living with HIV was a secret and that I shouldn't tell anybody until I moved to Georgia, actually, and I began my work at Sister Love, and I started to meet people who were living with HIV, who were open, and the impact that their story had on me and them sharing their story. So to answer your question, I just encourage people to do it when they're ready. Whenever you're ready and whenever you want to, it's your choice. I just want you to be comfortable in your HIV diagnosis and, be happy.
That's awesome. Thank you, Antoinette. Moises, is there any?
Yeah, we have some good comments around the ending the epidemic plan. Very quickly, we have a comment from Stephen Vargas. Absolutely agree with the idea we need to take a racial, gender, and social justice approach to ending the epidemic. Also, we have a comment from, I tell you right now, from Teresa Sullivan. And the comment is, where is Teresa? Is when you leave out the needs, voices of population living with HIV, the plan has gaps and mostly need redesign the plan to be inclusive of all people living with HIV and needs and life experiences.
Excellent. All right, so let's move on to the next question. What legislative changes do you want to see as a person living with HIV? And I'll go straight to the audience for this. And I know that Grizel mentioned some legislative changes. So tell us what you want to see. What changes to the End the Epidemic Plan? What changes do you want from your legislator? What are you going to ask for tomorrow as a long-term survivor of HIV, as a person aging with HIV? What are you going to tell your representative tomorrow?
This is a question for everyone, or?
Yeah, the question is for everyone, the audience. You can jump in, Grizel, because I know you did mention that in your feedback. So yeah, jump in and get the conversation started.
Yeah, I mean, I think kind of, and I'm starting to see some of the things come up in the chat, but yeah, again, thinking of ensuring that we're supporting ongoing research of long-term survivors, and also any other like services that really support the overall well-being and quality of life of folks who are living with HIV.
Awesome. I see in the chat, somebody says, I want $170 million added to the HOPWA budget. The first thing I would ask for is that they amend, oh, I lost it. I don't know if,
Malcolm.
I don't know if you caught that, Moises. Hold on 1 second, Linda. Let me see if I can catch that last one.
Which one?
I would ask for is that they amend the Older Americans Act to include those of us with HIV as a community's greatest need. Okay.
Yeah, here it is.
Yeah.
The first thing I will ask for is that they amend the Older Americans Act to include those EOF UAS living with HIV as a community of greatest need.
Awesome, awesome. Linda, what were you going to say?
I was going to say what is needed and not thought of is that there should be providing housing for those who are aging with HIV. This was never part of the plan. So, and when you're aging with HIV, I know that the senior accommodations that are currently around do not have geriatric care where there is a HIV specialist as part of that care.
Mm-hmm.
Okay, that should be included in the mix, and that's something that should be budgeted for.
And that is a good point, and we are definitely going to get to that in the next section. So before I leave this question, anybody else with what they want to see? I see a few other things that are coming in the chat box. Moises?
Yes, we have a good comment here from Victoria saying straight men definitely need to be heard from in all conversations. And also I have a great comment from Teresa. I want to ensure Title 10 funding remain part of the reproductive rights for women.
Hold on.
Sorry?
Yep.
Go ahead, Moises.
All right. So also a comment from Paul Aguilar. I have read and reread the National HIV Strategy at least 4 times. And within this 87-page document, long-term survivors are mentioned 4 times. That is 4 times.
Yeah, exactly. And that's why we're having this conversation. And that's what we want you to talk about when you go up to the Hill tomorrow. All right, so let's move.
Oh, hi. This is Terry Lynn from California. And one thing that I really think we need to look at is a comprehensive sexual education program. And not for me, and as the statement you made, even as a long-term survivor, almost 70 years old, I still have sex. But I'm turning around as an elder and looking at the young people coming behind me because they're the future. If we're going to end this epidemic, we have to give the tools to those that are coming behind us and teach them how not to get to where we are. I'm very grateful that I am alive. I'm not supposed to be, being 27 years, but I turn around and I look at my babies coming behind me. Mm-hmm. Without a comprehensive, inclusive sexual education program, which some of us didn't get, then this epidemic is going to continue, because it's basically about knowing your sexual rights, your sexual wellness, and what you need to keep from getting to the point where we are. So for me, it's not looking at me at almost 70, it's me turning around and looking at those that are coming behind me.
Excellent point, Terry. Thank you so much. We appreciate that. All right, so let's move on to the next topic. So Linda, you started to mention this. And so, as a woman living with HIV over the age of 50, what are your thoughts about, well, first of all, we were talking about the End the Epidemic plan, but what are your thoughts about and concerns about geriatric care?
Thank you. Yes, well, Terry, I want to tell you, I am 70. I'm over 70. I'm about to be 71, and I'm in very good health. And I am concerned about those of us who have been left out of the conversation because long-term survivors weren't mentioned in that plan, but was it 4 times? Because they really didn't expect us to be here. So now we are here, and there are things that happen to the human body as one ages, and we need to be able to distinguish between those things that are a part of simply long-term living and aging, and those things that may be impacted by our HIV status, such as bone density. I think Antoinette mentioned that earlier. Someone I saw in the chat talked about their cognitive abilities. Well, we know that cognitive decline, we see that in now with dementia and Alzheimer's, but does it really have anything to do with HIV? The research, I'm always disappointed when I see research projects that come on board. And I'm here in Atlanta with Emory University that does, but there's always this cutoff date at 40 or, 45 years old. Well, what about the research from 45 to 80? Because I also know that here in the Metro, we have a large aging and aged HIV community. There are many, many seniors that come through the Grady IDP clinic for care. So why is there not more research into how do you live? Because I would hope that Antoinette and Giselle would certainly live to 70, 75, 80, 100 years old, just like, and beyond the expected years of survival for those people who are HIV negative. And the reason I say that is because if we do the things that we're supposed to do being HIV positive, that is being and having access to care, taking care of our medications, taking care of our bodies on a regular basis, we'll be in much better health than the average Black or brown person in this nation because we are under continued care. And so I would like to see more research in that area.
Exactly. Thank you so much. So Ronald, I'm going to go to you. From a male perspective, is there anything different from what Linda said or from what Antoinette or Griselle has said about the End the Epidemic perspective or about geriatric care?
Thank you, Malcolm. And from my experience, I don't see anything particularly uniquely male from what has already been said. And I'm very interested in the experiences of those people on the call. But of course, I do, when saying that, I think I have to be as a man, recognize the gender-based disparities that impact care and certainly impact HIV care and the health disparities between men and women, and to be vigilant in dismantling and combating those disparities. But also, when you say a male perspective, I think that does raise the question of men's health in general and the impact that both HIV and aging have on men's health and as well as women's health, and to be more cognizant and research around that. We know, or there has been evidence or studies that show an association between HIV infection and increased risk of cancer. So what does that mean in terms of prostate cancer for men, and what are there any differences? So there are a lot of things that, as has been mentioned already on the call, that we need to know about men's health, women's health, and the differences, and how HIV infects that, and how aging. And I just want to also note that this conversation so far has really showed the nuances of what aging means, because already we are talking about aging in the chronological sense of years of living, but we also are talking about aging in the sense of years living with HIV. And Antoinette and Giselle, who have been living with HIV all their life, and 20s and 30 years, while they are in their 20s and 30s. So that dual sense of what aging means. And I also am an older adult living with HIV who is in 70 years of age. So I come with that perspective. And for geriatric care, one of my concerns is how knowledgeable are geriatric physicians are about HIV. And I think there needs to be more knowledge about the impact of HIV on geriatric care, and more of an integration of HIV into geriatric care, and more of a focus in HIV care on aging. So these are some of the issues that I see. Again, they're not necessarily uniquely male issues, but they certainly are ones that we need to talk about more and more.
Awesome. Thank you so much, Ronald. Thank you so much, Linda. Moises, what's going on in the chat?
Yes, we have a lot of comments and a lot of questions. We have here a question actually from Nicole Jones. Say, how does the Ryan White system need to change to meet the needs of long-term survivors and folks aging with HIV? There is a similar comment by Robert Riester. Modernization of the Ryan White Care Act to be updated to include the evolution of HIV care and treatment with respect to those who are aging with HIV. The care continuum should include education about aging with HIV to all providers. It should also include long-term care funding options. I think he was responding to Nicole's question. Very well said, Robert.
Very well said. Very well said. Matter of fact, I'm gonna give him a clap. Thank you. That is very well said. That is exactly what we need.
Malcolm, if I can, because I'm really glad that question about the Ryan White program.
Somehow I knew you were going to jump in. I just knew that.
I think it's time, and I know this is a touchy issue among many advocates, but I really do think it's time for us to take a hard look at the Ryan White legislation, and to see the changes that are needed, or may be needed. I personally think that we do need to look at how the eligibility of programs needs to be changed. We need more social services, particularly for long-term survivors and for older adults living with HIV who are dealing with isolation and social disengagement. And again, that affects people of all ages, but those issues are particularly acute among older adults. And there are restrictions, the 75%, 25%, 75% of the funding for primary care, 25% for social services. We need to look at that ratio and whether to which that restricts the ability of planning councils and local jurisdictions to redirect money to social programs that are very much needed for people, long-term survivors and including older adults living with HIV. So in sum, I really am glad that the issue of the Ryan White program has come up, and I think it's time for we as advocates to take a look at what kinds of changes, legislative changes to the act that may need to be made.
Ronald, there is a comment here that it relates to what you just said, but just add something that we haven't discussed yet. It's from Stephen Vargas and said, we need to encourage states that have not expanded Medicaid to do so in preparation for the vast numbers increased numbers of of people requiring more than just what's covered by Ryan White.
I'm glad that was raised, and I had it in my notes that Medicaid expansion needs to be on the table. There are still 12 states that have not expanded Medicaid, and 7 of those states are in the South. Texas, a large state, also has not expanded Medicaid. So I'm grateful for the person who raised that, because that Medicaid expansion should very much be on our issues that we bring to Congress and tomorrow.
And Georgia is also a state that has not raised Medicaid, and Georgia came up with a waiver program that the Kaiser Family Foundation, as well as the Brookings Institute, has said will not provide the services and cover the people that the state of Georgia said. They somehow got that waiver program approved during the Trump administration. But I understand that the Biden administration has come back and said, wait a minute, we need additional information, or we don't think that this is going to do what you say it's going to do, which is good. That throws it back to us as advocates to make sure that our state legislature does something to expand Medicaid. I'm very interested in people who would need Medicaid services who are between 50 and 65, for example, who are not yet ready for Medicare, qualify for Medicare, but without Medicaid expansion, they're just out of luck, and either they're going to Ryan White or they're paying exorbitant prices for things that are on the exchange where they don't fit into that qualification to get the proper amount of subsidies. So yeah, that is definitely something that I am working on with some other folks, and we definitely need to advocate for Medicaid expansion in the South, both at a state level and a federal level. So I'm glad that came up as well. Moises, what else is out there?
Hold on. Hold on. Yes, we have one comment actually from a vertical that I think we should, I want to mention. It's from Sean Mark. I was born positive for HIV, but through the course of life, I developed the AIDS diagnosis. I got better, then undetectable, but this happened 3 additional times after beating AIDS four times. My body was changed. My memory is definitely not what it was before. I was a performer, but have problems recalling lines I memorized. I'm only 31. I would like us to take a look at how our brains are affected by the disease.
That is awesome. Yeah, that is so true. That story is powerful, and I urge you to put that to your congressional representatives tomorrow. Your story is extremely powerful. And even when you go back home, put that to your state representatives. If your state has a statewide AIDSWatch, get out there and go and participate, because that is a powerful story. Very
And
powerful.
Malcolm, that also, once again, comes back to the need for funding for research. I have been positive for 35 years. So why not look at comparing what is happening with these younger people with someone like myself who has already lived with HIV for 35 years, and see if there is some things that can be learned from my experience, from my internals, for lack of a better term, that can be useful for the younger folks as well.
Exactly. You know, back in 2013, when I had kidney cancer, you know, thank God it was the kind of cancer that I didn't need chemo and all of that. They just simply removed my kidney. Yay. But I remember the doctor said to me, he said, we're seeing kidney cases like this, cancer cases like this in men in their, and I was in my 50s at the time, he said men in their 50s who have been living long-term with HIV. So we definitely know that either this or the medication that we're taking every day is having a detrimental effect on our bodies. And there's just not enough information out there about it. So I do appreciate everybody's feedback. So we talked a little bit about geriatric care, and then we started talking about Ryan White. But from a Medicare and a nursing home perspective, what do we need? I know my mom was in a nursing home, and this is an anecdotal story about the LGBTQ community. There was a man in my mom's nursing home who was gay, and I would listen to the nurses snicker and you know, say things. I wonder how often does that happen? And Lord knows if that man was living with HIV, you know, what kind of care was he getting? And you know, he's in a nursing home, and in Georgia, Medicaid covers nursing home care. So what does all of that look like? So for people living with HIV who are on Medicare, or people living with HIV who are required to go to a nursing home, what is that life like? I'm going to start with Linda. I'll start with you. Ronald, I'll go to you and see if you have any information. But I'm definitely asking folks that are in the audience if they have any experience or if they have any knowledge.
Unfortunately, I have absolutely no knowledge at all about what Medicare or Medicaid offers for those in nursing homes with the comorbidities of HIV and all the other things. I hope someone in the audience does have that kind of information that they can share with us.
Ronald, do you have it?
Malcolm, as one person in the chat has already noted, Medicare doesn't cover long-term care, nursing, so nursing home care. So I think those are two issues that very much need to be addressed with Medicare. And also Medicare in general, I think we need more attention to Medicare, particularly as we talk about long-term survivors and older adults living with HIV. Medicare is already a large provider of care for people living with HIV, and it's only going to increase. In a few years, the majority, or well over the majority of people living with HIV will be covered by Medicare. So we need to look at the issues of long-term care, nursing home care for Medicare, and that likely will include or necessitate some legislative changes, and we can guarantee that that will be a very controversial and difficult advocacy battle that we need to look at. Also, the fiscal and financial sustainability of Medicare, that needs to be a priority as we look going forward. So Medicare more and more needs to be on our policy and advocacy agenda. And the ages of Antoinette and Giselle, as I think you indicated, Malcolm, and given their hoped for lifespan, we'll be talking about HIV care in the 2050s, 2060s, 2070s. So we need to think about Medicare 30 to 40 years from now in terms of its ability to deal with what will be the majority of people living with HIV. So now is the time for us to have that long-range vision and the advocacy that is needed to ensure that there is a viable Medicare in 2050, 2060, which today's young long-term survivors will need.
Excellent points, Ronald. And thank you for that. I did see someone in the chat and it flashed before me, and I want to make sure that we don't exclude the trans community. Someone in the chat wrote that somebody in the trans community, and Moises, I don't know if you picked this up, that people in the trans community stop taking their meds before they check into any kind of nursing home or whatever out of fear. Moises, did you get that?
Yeah, I got that one. And actually, it's exactly what you said. That, people, when they transition and stop taking their medications when they are in nursing homes. So yes. That
is unacceptable. Unacceptable. And speaking of which, is there anybody in the audience in the trans community, or can you represent the trans community, that can speak to some of these issues? Unfortunately, we're not able to get anybody from the trans community onto the panel, mainly because of time, not because of anything else. We got kind of bogged down. So if you are, represent the trans community or a person of trans experience and you want to speak to these issues, I invite you to come off of mute and say a few words to us. Okay, all right. Well, thank you all very much for that part of the conversation. So yeah, we definitely know that there are a lot of legislative changes that need to happen to Medicare, and definitely some societal changes that need to happen as far as nursing home care. Moises, is there anything else?
Yeah, there was a comment by Jesse about that we need to look at the role of HAPWA in terms of long-term care.
That's really interesting.
If we we may need probably to unpack that for the audience.
Yeah, definitely. So long-term care providing for HAPWA.
No, HAPWA, what role would it play in terms of?
What role would HAPWA play? Yeah, well, I mean, housing opportunities for people with HIV/AIDS, right? If I'm 75 years old and I need to check in a nursing home, that's a housing opportunity, in my opinion. Legislators listen to, okay, I missed it. Yeah.
Jesse, you want to expand on that or not?
Yeah, Jesse, would you like to come off mute and expand on it?
I think I am off mute. So
okay, great.
No, but we're having so much advocacy around HAPWA. Maybe we should start thinking and actually saying not only is housing healthcare, but housing is long-term healthcare. And it's a conversation that maybe until this moment at AIDSWatch, we hadn't really crystallized, but maybe we should be crystallizing it, because we shouldn't be putting all of our eggs in the Medicare basket because everyone's looking there. But HOPA was created for us. Let's just own that. HOPA was created for us. It might have been created thinking that it would be temporary housing for us 30 years ago or 25 years ago, but its transition to long-term care is a logical extension of exactly where we are with an aging population. Let's just think about adding that to our advocacy agenda.
Awesome. Thank you so much, Jesse.
Hello, I'm sorry to interrupt. This is the interpreter. Would you mind switching out our interpreters, please, to Rhonda? Thank you so much.
All right. So let's go to the next section. What about your sexual health? Do you think that Medicare providers feel, as the kids say, some kind of way about providing sexual wellness to people living with HIV? What about us old folks? Terry said, you know, we're 70 years old, we're 60 years old, we're still having sex. So do we care about our sexual wellness? I think the answer to that question is yes, but let's have a conversation about our sexual wellness. So I'm going to ask the panel, I'm going to start with Giselle, and I'm going to ask the panel about sexual wellness. So Giselle, and then Antoinette, and then we'll talk to, let's see, then we'll talk to Ronald, and then we'll go to the audience. How's that? So Giselle, Antoinette, Ronald, and then the audience.
Yeah, I mean, I think in terms of providers, I often feel like the sexual health piece is often separated as like a cis woman. It gets separated into like gynecology, right? And so that really ends up being like it in terms of that. It's really just in terms of reproduction when it comes to cis women, which I think really is a limited conversation to having a more holistic conversation about like sexual pleasure, kind of like conversations that we're having with our sexual partners and that kind of stuff. And so I feel like we still have a long way to go around that. I'm also thinking about right now, as like U equals U has come more to the forefront, thinking through how how U equals U lands differently for folks who have been living with HIV for a long time and who might have a hard time even just like accepting that and like incorporating that message into their own personal lives based on like the stigma that we've had to live with all of these decades, right, around like disclosure and using condoms and all of that kind of stuff, I think could be some kind of like difficulty as well for folks who are long-term survivors when we're thinking about U equals U, condomless sex, and folks who are living with HIV for a long time. So I think we do have a long way to go in terms of becoming a more sex positive community. And I think just even talk like to Antoinette's point around sexual health education in the schools, I think we have a long way to go. I did have an experience several years ago at a like different clinic that I'm no longer at because I was running out of my birth control prescription. They had recommended that I switch my birth control. I was like, yes, I have an appointment. I'm going to switch my birth control. But in the meantime, can you still refill it? And really the front desk kind of like blocked me from talking to my doctor to get an extra prescription for birth control. And they told me you shouldn't be having sex without condoms anyway because you have HIV. And so, and that exactly. And so I stormed out and was out of care until I was able to switch my insurance and switch my provider. And so it really, like, thank goodness that I have been in good health my whole life and was able to like afford like a month or two off of medications until I switched. But just that experience really could have been detrimental to my overall well-being because of that kind of stigma, right? That kind of judgment around kind of like what I was needing, and really making assumptions about me and my life, just because, right, like they really weren't ready to talk about my own bodily autonomy, as well as like even thinking through, right, like U equals U, which I feel like for cis women and around reproduction, we have known for a long time. We, you know, like folks have been able to bear HIV negative children for a long time, so we've known U equals U, and so just even having to do all of that catch up and having to inform like the overall systems of care about it, in order to eliminate that kind of stigma.
Yeah, I can't. I'm just stuck on the fact that they told you that you shouldn't be having condoms. I'm still stuck there. I'm sorry. That is just Anyway, Antoinette, let's go to you.
I agree with so much that Giselle has said. So much of what has happened to her has happened to so many women living with HIV, people living with HIV, where we have to encounter situations where they're supposed to be professional situations or situations where we should not feel stigmatized, and we are, because we look towards these folks as, you know, doctors and people of higher education who should already know these things. And sometimes we, as advocates or as people living with HIV, we have to be in a place to educate our providers. And that's not sometimes, but oftentimes, you know, we have to educate our providers around just us, you know, and live with HIV and stigma around HIV and things that are not true. So do I think medical providers sometimes feel some type of way about talking about sex? Yes. Or they judge you about sex. I've gone into situations where they assume that the reason I was living with HIV was because I contracted it sexually rather than being born with HIV, and just so many other instances. So it's weird to me when medical providers or people who are, you know, my primary care physicians are hesitant or don't want to talk about sex, even though, you know, sex is how I got here and sex is, we're all people, we're going to have sex. I honestly, I never understand where it's like, why aren't you asking certain questions, or why are you expecting me to bring up certain questions or issues, especially when it comes to, you know, me having sex, me looking for preventative options, or even looking for ways to keep my partner safe, or bringing my partner into the space where they may need some education, you know? So yeah, I definitely think they feel some type of way. Up until recently, where I connected with a new provider, you know, I was in many spaces where I felt judged for the type of sex or my sexual activity or my sex life, or still continuing to have sex, wanting to have sex, wanting to have babies, all types of things, you know, as if I should not, because I'm a person living with HIV. But this year, you know, me connecting with a new provider who is sexually empowered, you know, who has worked closely with people living with HIV, women living with HIV, and been in the field for at least 25 years, and know, you know, in order for us to have like open conversations, biases aside, we're going to have to talk about these things in order to keep you healthy, you know, as a patient, and keep me informed as your doctor. So I definitely have experienced some of the things that Giselle said, and yeah.
Okay. Well, thank you very much. Ronald, anything that you want to add?
Well, both Antoinette and Griselle have covered the issues very well. I would highlight the issue that we shouldn't talk just about sexual wellness, but certainly from a sex positive perspective. And I'm glad that was mentioned, and I see it has come up on some of the comments in the chat. Also, really, this is another area where providers, as Griselle's example has clearly shown, that we need education of providers. certainly healthcare providers, but others, case managers, other people who have direct contact with people, just to get at, to further promote a sex positive perspective, to promote and to recognize the fact that older adults, including those of us in our 60s and 70s, continue to have an active and one hopes healthy sex life, and what that means, and how do you medical providers talk about their patients about sex and having a healthy and positive sex life. So these are issues that affect how we educate our medical providers and social care providers to enable them to have good conversations and to initiate good conversations without feeling discomfort about talking about sex with older adults and in particular. So, and I think that as indicated in the chat, you equals you has really changed the narrative of how we talk about sex, particularly for people who are HIV positive, and what that means, and their partners, discordant partners, the whole realm of sex and discussions and negotiations and staying healthy and enjoying a healthy sex life has been changed by you equals you, and we need more discussions about what the impact of you equals you has had on the sexual wellness discussion.
Excellent. Thank you very much. Moises, what does our audience have to say?
Yes, we have an interesting comment here from Craig Lamb. Says, since you equals you became known, our community have seen a spike in other STDs, but it is unclear if you equals you has a direct correlation to this spike. I think that speaks for how important it is to have a good relationship with your doctor in terms of like being able to monitor you for STDs if you're not using condoms. There is more comments. There is another one from Tom Villa, say doctors overall are uncomfortable discussing sex with their patients. And there's some other comments regarding this. It's a, hold on a second, where is it? A question say from Timothy, how has you equals you changed people's lives in sexual health? I think that's an interesting.
Yeah, that's an interesting question. I'm going to throw that to Griselle. Griselle, would you like to answer that question? Or
yeah, sure, absolutely. And I'm curious to hear about how it has changed for like older folks. I think from my perspective, the beauty of you equals you as well as PrEP is really kind of like being able to get to some kind of sexual liberation for folks who are living with HIV, right? I know kind of through the beginning of like the epidemic, like it really impacted the sexuality of queer folks, right? And so all of a sudden, like it was this expectation, right? Like you can never have condomless sex, right? Regardless of your status, because you just didn't know, right? And I think that continues to be a message of like a lot of young people when they come out as queer, like that's the first message they're hearing from their families, if they have a supportive family that they could come out to, right? It's like, don't get HIV, right? It's kind of like these two things, like someone's queer identity and HIV status gets coupled immediately. And so I think the beauty of you equals you and PrEP is that it disrupts that. And so I think there's an opportunity for sexual liberation for those of us for queer folks as well as for folks who are living with HIV, to like be able to reclaim our sexuality and sexual pleasure, and be able to have open conversations about condomless sex with our partners, right? And so that can come with STDs, that can come with unintended pregnancies, that can come with a lot of these other things, but it can also come with a level of intimacy that I don't think we were afforded to even think about several years ago before PrEP and U=U. And so I'm really curious about kind of like how that has played out in some of the older folks and other long-term survivors, precisely because we've been so programmed as people living with HIV that we need to have this checklist before we even engage in sex, right? And so you need to use condoms with every partner, you need to be undetectable, you need to disclose, you need to, like, this whole checklist that we have to go through before engaging in sex with people. And so, like, I think we need to, like, honestly revisit these conversations with folks who are long-term survivors, who may be like heavily impacted by all of these decades of that kind of messaging that was limiting based on the science at the time, right? But now that we know, like, are we having open conversations? If folks are still feeling ashamed of talking openly about their sexuality and sexual practices, it is hard to talk about STD prevention. It is hard to talk about, right, just the need to get tested more frequently, to have these like conversations with your partner or partners, right? Like we just need to get more comfortable talking about it, not just with the physician, but also in like support groups, also with your case manager, with health educators, and all the folks providing additional supportive services where we might be able to talk more openly about the kind of sex that we're having.
Something on the line for what you just said. It's kind of an advice from Craig saying that if your primary care physician is uncomfortable with discussing sex and you're able to find another, fire him or her. That's so true.
Exactly. Thank you. So Linda, do you want to, Linda or Ronald, do you want to answer? Giselle expressed an interest in hearing what older folks have to say about U=U and their sexual health and their sexual life.
Well, let me say that it's interesting because several years ago, we did a study, Project Eben, which was a study of serodiscordant couples. And we found that many of the, and these were heterosexual couples, many of the men and women in these relationships, and they were long-term relationships, were having condomless sex. And that was before U=U was approved by CDC. And I think part of that is part of what led to it, those kinds of studies. But what we did find is that the men were very, very anxious to have other men to talk with. So now we're back to our earlier part of our discussion about support services and expanding upon those services that are offered to people living with HIV. We need to have the ability to have those who are seniors to have these kinds of support services, because right now everything is directed once again to an under 40 group.
Right. Linda, were you finished or did you freeze? I'm sorry.
No, I'm
Okay.
finished. I'm finished.
Okay.
Yeah.
Okay. I'm sorry, because yeah. So yeah, I really like some of the comments that are in the chat. I think Stephen said we need to own our age and wear it as a badge of honor. Moises, what else is going on in the chat?
Yep. We have comments like, aging with HIV, we must not be afraid to talk about our sexual wellness. Also, we have a comment too about like people saying their experience from Paul Aguilar. I said Osor dated for so long that now it's hard to even consider dating someone who is HIV positive. That's Paul Aguilar using serosorting. Yeah, those are like those that come the more.
Okay. All right. Well, those are the questions and those are the things, the topics that we decided that we wanted to talk about today, but we still have 10 minutes. So what did we leave out? We had this fantastic panel of people living with HIV, either born with HIV or living long-term with HIV, some older than 50, some younger, a pretty diverse group. As I mentioned, unfortunately, we did not have someone to represent the trans community, but we'll fix that. But what did we leave out? What else do you guys want to talk about?
Well, Malcolm, my name is Malcolm Williams, and I'm from Nashville, Tennessee, and it's good to see you again. And but I feel as far as you with you with, that was a great thing because I found out about it my first time at AIDSWatch when Bruce Redmond came out with that, and I think that was a good thing that came out because I wasn't to say, well, I'm taking my medication and I'm and I'm undetectable. Reward me for doing this hard work all these years. And when you came out with that, that was the best thing that ever happened, as far as I'm concerned. But even if I do get, I'm not in a relationship now, but if I was, if that person doesn't want to at least get tested, if he don't care enough to do that for me, then I don't need him in the first place. And so, and like I said, even though I'm undetectable, I still would prefer to use a condom when I have sex because that doesn't mean that he doesn't have something that he's bringing to me, and I don't need to have that upset like that. So, you have been a helpful thing for me. Thank you.
Thank you very much. I appreciate that. Anybody else?
This is Helen Turner in Dallas, Texas. Can you hear me?
I can hear you, Helen.
I have lived with HIV for 37 years. And You Equals You gave me hope. I'm 75 years old, and I consider that now is the time for me to get back in the market.
Good for you. Yes.
But
yes.
COVID came into the picture.
Yeah, that COVID comes along and messes up your dating life, right?
And it messed my dating life up. At my age and comorbidities, I had to just chill. But I'm still in the market. It's just going to take me a little longer because now I'm fully vaccinated, I can start back to look again.
Mm-hmm. Now that you got your shot, you can go get a shot, huh?
That's right. Thank you.
I love it. I love it. Thank you so much, Helen. I appreciate that. Who else?
We have Timothy. Tim, your hands are raised.
I want to tell everyone that I have Lou Gehrig's disease, and it's my comorbid disease now.
Okay.
And I can't walk anymore, and I really hope that everyone continues with their life and live as long as they can, because I pledged that too.
Well, thank you so much, Timothy. We appreciate you. We appreciate you sharing that, and we wish you well.
Thank you.
Who else, Moises?
There is a comment here by Leslie, and it said, I just had the conversation with my doctor about sex. She didn't seem to be very surprised that I was as open with the fact that I don't like using condoms, because I am an advocate and have been positive for 21 years. I should know better about using condoms. I felt that she was talking down to me, but I told her if we can talk about sex and be respected about how I choose handling my sex life, I can find another provider that I can be open with. Just because we're advocates, we should not talk open about our sexual health. He was questioning the doctor with that.
Exactly.
So I'd like to weigh in on that. I think the other piece, right? So we're talking about this from a perspective of sexual health, but I also think overall, like in the field and particularly from like a medical perspective, we need to really think about bodily autonomy of folks living with HIV. I feel like our bodily autonomy is often infringed upon, right? Whether it's about the type of sex we have, but also just about medical decisions, right? And I think we need to be trusted and we need to have a trusting relationship with our doctors to talk about what we want to do about our lives and our health, and right, and really be able to make it a partnership, but at the end of the day respecting that it's our bodily autonomy and we can like that we know ourselves better, right, that we know ourselves best, and that we should be making both from like lifestyle to medical decisions, really in partnership and not as like doctors know better. Yeah, because I'm like, you know, like I know that the science is catching up with what we've been living with all of these decades. Right, as the example that we've talked about with U equals U, like folks have been having condomless sex for a long time, and the science had to catch up, right? But before then, it was a shameful thing to talk about, right? Like you couldn't openly talk to your providers about having condomless sex, couldn't have honest conversations because we would be judged. We would be told like, no, you can't do that. That's not, you know, you're not being responsible or whatever it is. And I think just bodily autonomy goes beyond like our sexuality. I think it really goes into any kind of medical decisions, and so I feel like we also need to do work to change that in the practice of HIV care.
Excellent, Grizel. Thank you so much. So we've only got 3 minutes left, so I want to start to wrap up. So I'm going to go through the panel, and I'm going to start with Ronald. Ronald, what closing remarks do you have?
Well, first is to thank my the other panelists. I think you've been terrific, and all of the participants. When Malcolm, Moises, and I were started pulling this conversation together, and that was our goal, to have a conversation, to hear, to listen, to talk with each other, and even from the confines of a virtual environment. I feel that we've accomplished that, and I think we have a good start for our conversations with the congressional offices. So I want to thank the panelists, the participants. This has, from my perhaps biased perspective, has been a good conversation and exactly what we were hoping to achieve.
Exactly. And then I'll piggyback and I'll switch direction. I'm going to go to Moises. And Moises, what are your thoughts?
I think this was a fantastic session, and I love how engaged everybody was in the conversation, the topics that were brought, and it showed that, you know, this is a well-informed community, and how, you know, we can help each other, right, to understand what are the issues that we need to advocate for, being, you know, in our district or being now in the Hill when you go tomorrow. So, you know, important to keep in mind the discussion about right and why, about Medicare, Medicaid expansion. Those are issues that, you know, will be important to bring up with your legislator tomorrow. So this was a great session. So kudos to everybody.
Thank you. Yeah, thank you to everybody. This was great. Thank you to everybody for your participation. And thank you to the panelists, Linda, Antoinette, Grizel, and Ronald. All of you guys were great.
I just wanted to say one thing. I put it in chat. They found through my ALS DNA, my ancestors were Vikings. And I want to pass that warrior mentality to everyone on this call.
Well, I think that says it all, right?
Thank you.
Thank you all so much for the work that you do. More importantly, thank you for the work that you will do tomorrow. Get out there, advocate, agitate if you have to. Don't agitate in the meeting, but when you get back home, if you need to agitate after you advocate, then go ahead and do that. But we need to get some change going, and I think with people like you, we will. Thank you all so much.
And this is all the more reason to vote.
Exactly.
So that we get people in the legislatures that will listen to us.
Exactly. Thank you all so much. I think we're going to drop. Ashley, is that it? Are we done?
Yeah.
Take care.
All right, everybody.
Everyone.
Thank you, Malcolm. Thank you, Moses. Thank you, Ron.
Thank you.
Nice job, panel.
Thanks.
Fantastic. Thank you.
Thank you so much.
Nice job, panel.
Bye-bye.
Great. Bye-bye.